Hello, welcome to this webinar for AMP leads and principal social workers in this time of COVID, and to help you hopefully with the situation that's affecting all of us at the moment. Thank you very much for joining. My name is Ruth Allen. I'm the Chief Executive of the British Association of Social Workers, PSWs, and I'm going to introduce the panelists that we have here today. So, Claire, do you want to introduce yourself?
Hello, my name's Claire Barcham. I am an AMP and I manage an emergency duty team in central London. I also chair PSWs Policy, Practice and Education Group. Thank you. Steve.
Hello, I'm Steve Chamberlain. I chair the National AMP Leads Network. I'm not now currently practicing as an AMP, but I'm also a member of the Policy, Practice and Education Group, Mental Health Policy, Practice and Education Group at PSWs.
Thank you. And Mark?
Hello, I'm Mark Trewin. I'm the Mental Health Social Work Lead at the Department of Health and Social Care. I work in the Office of the Chief Social Worker, and I'm currently supporting a range of people in the Department of Health and NHS England in Covid-19 planning.
Thank you. So we have about over 130 people joining us right now. So thank you very much for joining us. And we've organised a webinar to provide what we hope will be a useful information, supportive session as well, because we know these are absolutely extraordinary times and you're being challenged on a daily basis, and there's a lot to take in, both about how we cope within our current arrangements, our daily ways of doing things and how they're being changed and challenged by this situation, but also so that we can all understand some of the changes that are coming, the legislative changes, policy changes, and the kind of imperatives at a national level. So we're hoping that this will be really helpful for you. This webinar will be recorded, so it will be available afterwards for anybody to access, including yourselves. There will be resources available for you, which will include slides that you're going to see. We're also going to suggest that if you have resources that you want to share with others, that you might send them through, and they can then be added to the resource section of this webinar. So we're going to start with some presentational material. We're going to have presentations with some slides from Claire and then Steve. And then Mark is going to talk about things from the Department of Health and Social Care perspective. I'm going to chair, and after those presentations, which should take probably about 20 minutes, we'll then go into question and answers. And we've already had quite a few questions come through in advance, which is really helpful. We'd like you to use your chat box. It should be fairly self-evident about how you can add your questions to the screen, and then they will be moderated. Take some of those. We're probably going to have a lot more questions than we can answer. I'm sorry if we don't get to yours. We will be able to address those issues in different ways. Perhaps some themes will come through from many people and we can pick that up. But also we have another webinar on Monday, which is aimed at frontline practitioners. And it may be through also, there'll be a crossover between some of your questions and some of the questions we deal with then. What we won't be able to do, of course, is provide lots of detailed advice on particular issues, particular contexts. So we will be answering questions in a fairly generalised way, but I'm sure you will understand and appreciate that. So I'd like to turn now to Claire, and who's going to run through the first section, and I'll allow her to introduce the purpose of her presentation. Claire, over to you.
Thank you, Ruth. So the purpose of this part of the presentation is to actually go through the flexibilities that already exist, particularly where we're thinking about approval of AMPs and some of the issues around refresher training. So if you go to the next slide, please. So what you have here is the actual wording of the regulations. So it tells us some of the things that we need to do. And what I'm going to do is I'm going to take you through to the next slide, which is the explanation. So what it means is anybody you approve must be a registered professional, obviously, a social worker, OT, nurse or psychologist, and that as a local authority, you must be satisfied that that person has appropriate competence. But actually, beyond taking account of what the AMP competencies say, how you satisfy yourselves is up to you. There is actually a lot of flexibility there. I know there's good practice, but actually in an emergency, the thing that we need to do is satisfy the law. If you have somebody who has passed their AMP course, but has never actually been approved as an AMP, as long as they pass that course within the last 5 years, they can be then approved, still approved as an AMP. If it's longer than 5 years, they can't anymore. If you have people, and I know a lot of people do, who have been AMPs, but their AMP status has lapsed, they can be reapproved, and it's up to each local authority to determine why they are satisfied that somebody has the appropriate competence to practice as an AMP. And again, that's very flexible. So you could do that in a number of ways. Next slide. So where we're looking at people who need reapproval, so i.e. at the end of 5 years, what you're being asked to do by the regulations is confirm that the person is still a registered professional, that they've completed their 18 hours of refresher training, and that the person has the appropriate competence. But again, how you satisfy yourself about the required training is up to the authority. Now, I'm going to just go over to Mark and ask a little bit more about that, because I'm sure the issue of 18 hours is a cause for concern. What would the DHSC's view be?
Well, what I've done is sent through a report to my colleagues in the Department of Health and Social Care, raising some of the issues that have been raised with me by AMPs and all of the issues that Claire's talking about at the moment. And that's being looked at now. I think the opinion of us, having looked at some of the regulations, is, as Claire rightly says, there's an awful lot that can be done already with the regulations as they stand. However, the issue around 18 hours refresher training is something that's very strictly in the regulations. And so we have asked DH lawyers to look at it to see whether or not any action needs to be taken in light of that request. So I can come back to you on this later after they've had a look. But one of the things that I'm doing is making sure that the Department of Health and Social Care is aware of all of the issues that might be happening across the country and the views of AMPs. And they're taking that very seriously.
Thank you. Next slide. So in terms of refresher training itself, at the moment, what counts as refresher training is up to the approving authority. So you have the choices around doing legal tests, reading, or face-to-face training, actually quite a wide range of things. Steve, you and I have talked about this quite a lot, haven't we?
Yes, we've talked about it recently. I think that historically, I think there's been a significant resistance to move away from face-to-face training for obvious reasons. But I think given the extraordinary circumstances we've got at the moment, we're able to go back to say, to reinforce the fact it's never actually been formally tested. Now, there's a possibility, and Claire and myself have started talking about this, about maybe there may be some possibility of provision from someone, maybe from us, maybe from someone else, around PowerPoint presentations, training presentations that are usually used as face-to-face presentations, to allow people to use them and count them towards the 18 hours or whatever is allowed. So that's something that we've just started talking about now as a possibility, depending upon what is going to be required.
Thank you, Steve. That's really good. Next slide. Another question that comes up quite a lot is about processes for approving AMPs to act in more than one local authority. Now, AMPs must be approved by one authority, but they can be authorised to act on behalf of more than one local authority. So you can do this in a fairly straightforward way. You need to agree this at a strategic level, that the local authorities are happy for that to happen, and then they need to write to all the affected AMPs confirming that the approving authority plus the different authorities that they are authorised to act on behalf of. This would make it clear the AMP would be indemnified for the work they do. Now, I know there's some good examples out there where authorities do already authorise AMPs to act on their behalf, where they're approved by a separate local authority, and that's the sort of resource people may want to share.
Yes. Can I just come in there, Claire, because it might be useful there for people absolutely to share examples of good cross-boundary working and collaboration. It's quite standard in some parts of the country, and then in other areas perhaps it's quite alien. And in this current situation, people knowing that they can work in that way and get those protocols in place might be really, really important. And just, are there any issues for working, if people are approved to work across boundaries? You know, do any issues come up, and how might they be sort of mitigated if they do?
I think the one thing is clearly bringing your workforce with you, because there will be concerns from frontline AMPs about what that would mean for them in terms of their workloads, and also in terms of the indemnity that they might have. So I think that's important. I also think that there are some issues that obviously arise where, because of bed shortages, people are being taken for long distances. That's a slightly different issue, but I think it does cause problems. And I think it's an area that I suspect AMPs would like more clarification around.
Yeah, thank you. Is there anything else that you want to say on your presentation before we move on, Claire, to Steve, who's going to talk next about amendments in the emergency legislation that's before us?
I think just to invite Mark to make any comments that he might like to on that issue of approving and acting on behalf of different authorities and the cross-border issues.
Yeah, thanks very much, Claire. I mean, this is something that I've been talking to NHS England and to the Department of Health and Social Care about. I think there's a number of issues here. If you take, for example, the concept of Section 2 to 3 assessments in out-of-area hospitals. Now, as you know, the code of practice is clear that it's the detaining authority that ought to do it. But if the country is in lockdown and we're not supposed to be travelling and we're supposed to be socially isolating, it may well be very difficult to do that. That means that it's easier for us to have a blanket agreement across the country that for the period of COVID-19, we will do the assessments that are in our area. Now, of course, the problem with that is that if you have 2, 3 or 4 private hospitals in your area, you may find yourself overwhelmed with work. So one of the things that I've raised with DH and NHS England is about us having a real understanding of what that means in terms of resources and support to local AMP areas. And I shall come back to anybody when I've got some responses and decisions about that. In terms of acting across authorities, I mean, having a view across the country, I know there's lots of areas that do that very well. I know that London at the moment is having a lot of discussions about pan-London agreements on AMPs. I know you're involved in that, Claire. I think the clever way of doing it, I suppose, is not to make it too complicated. We don't want all AMPs to be authorised by all authorities in their area. What we want is an agreement between the authorities that if AMPs are helping each other out across areas, across boundaries, that all of the local arrangements will be respected no matter where they're working. So that's something for the local authorities and the ICSs and the STPs to get together and agree that as part of their pandemic planning, I think.
Okay, Thank you. Right, thanks, Claire. I think we're moving on from you now, and we're going to Steve. And Steve, you're going to talk about the implications of the emergency legislation, the temporary legislation, the coronavirus bill for AMPs.
Yes, thanks, Ruth. Can you go on to the next slide, please? And one more. Next slide, please. That, lovely, thanks. Right, I think we've gone one too far. Back one, please.
It's there, Steve. I think it's showing.
Right, got there. Lovely. Okay, thanks. I think a lot of you will have probably read this already and had contact. I mean, the links have gone out through various sources, but this is just to cover what we've got. Of course, these are defined as temporary modifications to the Mental Health Act, and although there is no timescale, just to say that these will only be initiated if things get very severe, and there is no commencement date. The bill includes an element around the whole range of different changes to a lot of different pieces of legislation, and the commencement date will be in the gift of the government, of the relevant Secretary of State. So these are not automatically going to start, even if the bill, or if and when, I'm sure it will be passed very quickly and become an act. So I think probably a lot of people will be aware of this. I mean, the plan is for the Section 2 and Section 3 applications not to require 2 medical recommendations. They can be founded on the medical recommendation of a single doctor, but, and this is something that most media are missing out on, of course, as they always do, is that it's the AMP's decision still. It is the AMP decides whether or not compliance with the Act, the delay which will happen to comply with the existing Standard Act, is impractical. Sorry, it's impractical, not impracticable. I did change that because I've questioned that later on. Impractical, or would involve undesirable delay. I'll come back to those words later on because I think we need to just think about them at the moment before it actually gets enacted. Then an application must include a statement. So the AMP, if it comes to that stage, the AMP will be required by law to make a statement on the forms about why a delay would be impractical or unreasonable, or why they're using just one doctor. So you can't just go down that route automatically. You will not be able to use a non-Section 12 approved doctor. The doctor, if you use a single recommendation, it will have to be using a Section 12 approved doctor. And the doctor does not have to have had previous acquaintance. Now, this is effectively turning Section 2 and Section 3 into Section 4 whilst retaining the existing timescales for Section 2 and Section 3. As a result of that, Section 4 is being suspended, or would be, if this is enacted, would be suspended. So there will be no need for Section 4, because you would be able to go straight to Section 2 or Section 3 with a single recommendation. Can we go forward one, please, Steph?
Can I just ask one question? Would that be okay? It might be for you, Steve. And it's just about what severity of the situation might mean. You know, what would that look like in order for the Act to be, for these different provisions to come live? And maybe I'll just put it in there as a bit of a question, and maybe Mark, when you come to speak, you might just see if you can address that. I appreciate it's probably very difficult. Steve, Steve, you want to go on?
That's going to be my final slide, really, about some of the questions around the actual words that are being used in the amendments. So Section 5, the proposal is to double the time, well, it's not double necessarily, to increase the time limit. So both Section 5 holding sections. 5.2 time limit being increased from 72 hours, which of course is 3 days, to 120 hours, which of course is 5 days. And a 5.4, of course, which would be by a mental health or learning disability nurse, time limit increased from 6 hours to 12 hours holding sections. With places of safety, the proposal is for the time limit for initial detention in a place of safety to be increased maximum time from 24 to 36 hours, which of course is now only permitted following an extension by a doctor. The 12-hour extension will continue to exist, is not being affected by this, but of course we need to remember that the legislation on the code explicitly excludes extending it due to lack of resources. It's about the clinical condition of the patient. So, and there's no mention in the legislation about that. It's just that the standard time limit will increase from 24 to 36 hours in terms of holding somebody at a place of safety. Next slide, please. So for part 3 patients, there's a few bits about this, and I have to say that's not my strongest point, but for section 35, I think, and 36 as well, there is currently an overall limit for a remand to hospital for reports, an overall limit of 12 weeks, and that is being removed. So there will no longer be a limit for somebody to be remanded for reports to court. Again, not dissimilar to the previous stuff, that there were the various powers of the court to detain an accused or convicted person in hospital will be on the evidence of a single doctor rather than 2 doctors. There is a specific bit for those of you who are forensic experts around 45A and the need for the doctor to give verbal evidence to the court. Again, similarly, around transfer directions to hospital under section 47 and 48. And currently, if the person is not transferred to hospital during that time, a new direction would have to be given after 14 days. They're changing that to 28 days. And again, the words are similar. This would only be allowed if it's considered impractical or would involve unreasonable delay. So those same words apply. Just to say that there are a number of changes to the Scottish legislation which are similar, but obviously different. The Scottish legislation is significantly different to the England and Wales legislation. They are relaxing timescales, talking about the need for 1 medical practitioner rather than 2, and using the same words of impractical and unreasonable delay. Okay, and well, the one thing I haven't mentioned, which doesn't immediately impact on AMPs, is about the reduction in or relaxation of rules for SOADs and second opinion doctors, but I'm not going to go into that because it doesn't immediately impact on us. So one more slide, please. I think this is the last one with a bit of a discussion. So this comes back to what Ruth was saying almost, really. I was just aware that the words now in the bill are if a delay, it is impractical. And of course, the words, I've tried to compare it to the existing words in the legislation around the AMP's duty to consult with the nearest relative on section 3 applications, which we would not do if it's not reasonably practicable. And we all know how detailed the discussion's been about what practicable means. And I just wondered, is there a difference in meaning between these 2 terms? I get the feeling as a non-lawyer that impractical sounds less onerous than not reasonably practicable, but I don't know whether that is. And I've already posted to the Mental Health Law Online group to ask lawyers their view, but I haven't had a reply. Similarly, the words undesirable delay are in the bill and in the 11.4 duty to consult with the nearest relative, we would not consult if it's an unreasonable delay. Is there a difference in meaning between these 2 terms? Now, this might sound just obsessional, but AMPs are going to have to write on their forms why they consider that waiting for the second doctor is impractical or causing undesirable delay. So I think we will need to know, what that means. And as Ruth has said, think about the implications for that and what circumstances would lead us to that. Having said that, going back as often as courts often do to the will of Parliament. Parliament are doing this because they think there's going to be a very severe shortage of staff. And so thinking about that, I'm not surprised if they're thinking, well, if it gets that bad, then we will have to make it easier for you to make that decision. But I think it's important for us to actually get a bit of clarity about whether or not there's a real difference between this terminology. And finally, just before we finish, just about the statutory form, because on that form will be, there's no place to write anything on that. The bill does allow us to modify it with appropriate amendments. There will be no new statutory forms issued. We can just write. I think it'd be useful to have a form of words that's agreed across the country, saying amended due to Coronavirus Act or whatever it is called. So I think that's about it.
Thanks.
Me, yeah.
Thank you, Steve.
Yes, that's right.
Yeah, thank you. I was just thinking that all of this raises the key point that AMPs are going to have to be, as they always are, in this new situation, perhaps more so and differently, really on top of how they're upholding the decision that, you know, a shorter or simpler or less detailed way of dealing with the situation is kind of ethical and appropriate. You know, that sense of you know, AMPs being, you know, working together as a group to have clarity about, you know, and confidence around some of these kind of decisions, that's really thrown up, I think, by this. There's just a quick comment, really, we might come back to that. There was just one other question I had, Steve, I don't know whether it's for you or anybody else. It's about the use of remote joining, remote meetings, Skype, FaceTime, I don't know, other things to actually carry out Mental Health Act assessments, and whether that's, you know, whether that's legally considered appropriate. I think Mark's going to come in on this, which would be really helpful, because one of the key things we need to pick up on is how do AMPs manage their work in a very practical way in terms of personal safety of people using services, etc. Mark, did you want to come in on that one?
I did, yes. I just to say that I've been talking to a lot of people recently about the practicality of remote decision making in all kinds of environments. And one of the things that I was asking was amongst the tribunal and judges and mental health managers and mental health administrators around the tribunals and managers' hearings. And I noticed that I think this morning the tribunal judges made a statement and put it out on social media saying that they were willing to look at remote meetings and Skype in order to, and also what they're calling paper meetings, where they make a decision based on the papers in front of them rather than having large gatherings of people around. Now, I don't have that same kind of clarity around Mental Health Act assessments, and of course the problem with Mental Health Act assessments is they have to be done in a suitable manner, and it's not usually been seen in the past that a suitable manner is not being in front of the person that you're assessing. But what I have done is again asked Department of Health and Social Care to look at that and to consult with their lawyers, if that's possible, to look at whether or not that's possible, that would be possible, and whether or not there's any tools that we can use to be able to undertake the assessments and also sign the forms in a remote way, as long as the principle of the Act has been met in the work we've done. So that's an ongoing process that I don't have an answer to at the moment, but it's certainly something that's being looked at.
That's really helpful. Obviously, we're going to come back to these themes. And do you want to say a bit now, Mark? Are you going to talk about what's happening within DHSC and some of the things that you're working on?
Yes. Yes. So, I mean, I won't take very long with this because I want to get into the questions. I just wanted, first of all, to thank everybody that's been writing to me, because my email inbox is full of AMPs asking really exotic and interesting questions or making really helpful suggestions. And that has been the basis, together with the ones that Steve and Claire and Ruth have got, for what we're trying to do here today. And just, I also wanted AMPs to know that your voice is very strong within the Department of Health and Care, because I do understand it doesn't often feel like that. especially when you're looking at media and government pronouncements where social care and social work isn't always at the front of it. But in actual fact, both myself, Mark Harvey, Fran Ledra, the chief social workers, and a whole range of other people from ADAS and the LGA are regularly putting forward the needs of mental health and the needs of AMPs within the department. In terms of what's happening with the department, a lot of AMPs are asking me, when's guidance coming out for AMPs? And I think the honest question to that is, at the moment, there is no actual plan for specific guidance for AMPs. However, that could change because we have put in a formal request for us to consider whether that's necessary. But I would like people to think about the guidance that's already coming out and is about to be planned, because what we're trying to do is to make sure that AMPs are included in guidance that comes out. So, for example, the Chief Social Worker's Office had a lot to do with the recent guidance around discharge from hospital. There's NHS England mental health guidance that's coming out that we're working with them on. We've got obviously the bill for COVID-19. There will be guidance coming out around the bill, and we are working very closely with the mental health team, and the workforce team within the Department of Health and Social Care on that as well. Now, what I will be doing is keeping an eye on all of that and looking to see whether or not there is a need for specialist guidance for AMPs on top of all of that. But as we've seen today, as we look through the law and examine the regulations in detail and ask for advice, what we are hopefully finding is that there's a lot of freedom for local authorities to be able to make sensible decisions. I think one of the things that Steve was talking about was, what do these words mean, and what's the spirit of the Act? And of course, there's a lot of concern out in the public at the moment, particularly amongst people who have experienced detention under the Mental Health Act, that feeling that the law is quite draconian, which of course you can interpret it in that way. But I think that in actual fact, what the law is designed to do is to give flexibility in extreme circumstances where we may not have the staff, either on the AMP side, the nursing side, the social work side, the Section 12 doctor side, and that's how we should see it. So I think that's the process that we're trying to put in place here, is to enable us to meet our statutory responsibilities in times of where a lot of our staff may well be off sick, or because of underlying health pressures, unable to attend to certain aspects of the role. So that's all I wanted to say about that, because I want us to use the second half of this to go through some of the questions that have come through, and where we can either give some specific answers or be able to put them in a box to find out what's the next stage. Back to you, Ruth.
Thanks, Mark. Just a few quick comments and then we'll get to the questions, but I think they may link to some of the questions. I was thinking about the ethics guidance, actually, Mark, that's also come out.
Yes.
So
thank you for reminding me.
Ethics guidance mainly for employers, planners, commissioners, but actually relates to very much relates to practice, ethical principles for practice, from Department of Health and Social Care for social care workers. That seems to be an important document for AMPs and AMP leads and PSWs looking at as well. Did you want to say anything else on that before we go to questions?
Yes, thank you for reminding me. That was on my list and I missed it out. Fran and Mark would kill me for that. So yes, that was written by the chief social workers with lots of help from their team and various others. And it is specifically designed to give an ethical framework to the very difficult decisions that are going to be made across adult social care in terms of the Mental Capacity Act, DOLS, and the Care Act, as well as the mental health situation. And one of the interesting things is that it's been extremely well received across the whole of the care, and a lot of people are interpreting it or are including it in the guidance and the work that they're doing. So for example, yesterday I had a conversation with NHS England, who found it extremely helpful and wanted to link to it from the work that they're doing as well. So I think that's something really important for us as social care professionals to be able to use practically.
Thanks, Mark. So that's available on the Department of Health and Social Care website now. It's the social care ethical guidance for coronavirus. So we'll turn now to some questions. We've got some questions coming in, and I'll just pick up on a couple. to start with, picking up on some different themes. And one of the key themes, I think, for social workers generally is actually personal protection from risk of infection, and whether and how that might apply in the AMP for AMPs. And there's a sort of related specific question. Actually, let's pick up on that first. The issue of the well-being of AMPs and personal and protective equipment and expectations in relation to that, and changed working practices in how assessments are carried out. Would anybody like to kind of comment on that and thoughts about how that can be taken forward? Mark, do you want to come in first on that?
Yeah, I'll just say something very practical at the beginning. Is one of the things that I've been is the PPE equipment that is being made available to nursing and hospital staff, and now care home staff, also available to social work staff? And I noticed that there was something that came out yesterday, I think, that talked about how to get deliveries of PPE, and it sounded like it was particularly for care homes, but when you read to the bottom of it, it actually stated for all health, social care homes and social care organisations. So I think that's something that I'm following up to see about whether that can, because I know a lot of AMPs have raised concerns about the lack of access to PPE equipment for them. In terms of the other point that you made, which is around personal protection, and I know lots of areas have very good lone working and other issues, other policies that are very well put out. One of the things that I think I'm hearing across the country is organisations, especially across health and social care, looking at how to share and support each other, especially when out of hours or having to go into people's homes. So, for example, if you've got an out of hours in mental health in any particular area, is likely to be either an AMP team, a 24-hour AMP team, or an emergency duty team, or a mental health crisis team. And I'm hearing that lots of areas are looking at how they can share and support all of those staff together in a coordinated way.
Great, thank you, Mark. Claire, did you want to come in?
Just to say that if you haven't done so already, it's really useful to make contact with each local authority's emergency response teams, because they're coming together across health, social care, the police and so on, and they're coordinating a lot of this stuff, and including access to some of the resources. So they're a really important resource to plug yourself into if you've not done so already.
Okay, thank you. So there's a specific question which perhaps leads on to that, is somebody asking from our participants, what if we need to detain someone with symptoms or who has tested positive or is in self-isolation? There's different issues there, aren't there? And I was wondering about actually the kind of choreography of assessments, proximity, who's there to provide, to ensure that the space can be made as safe as possible. I just wondered if you had any thoughts about that, or about what good practice might look like. Claire, did you want to come in on that?
I think just to say, first of all, that certainly in London, the trusts have given quite a lot of thought already to some of those issues around where do people get admitted to. In terms of thinking about, well, how am I going to do this safely? As you say, Ruth, I think it is about coordinating the factors in the way that we've always done, but also thinking about things like distance, about access to maybe gloves, to be able to actually have that interview in as an appropriate way as you can, given the circumstances you're in. But I think I will be reassured that there's an awful lot of thought that is going around in health about how to manage this on wards. Okay,
thank you. I think that, the issue about physical safety is going to come up again and again, isn't it?
I think so.
I'm sure. There's a question also that's come in about advocacy, and we know that people's access to advocacy, and I guess the question is there any guidance for accessing advocates? And I guess the question then on from that might be, what do we anticipate changing that could be a real quality issue, couldn't it, for detained patients, and a human rights issue as well. Mark, did you want to come in on that?
Yes, I wanted to come in because I was aware of a big debate amongst mental health administrators around, and somebody wrote to me yesterday saying that they had actually spoken to an advocate who'd had their first ever advocacy interview over the phone, and then with someone else by Skype, and the feedback from that was, it's not as good as it should be, but it's better than nothing. and I think that's one of the areas. And I think now that we know that that there's a general acceptance that these things can be done remotely, then that is the way I think a lot of people are going to want to do it, with the acceptance that it probably is good enough in terms of the standards that we want to keep, but that it's better than not doing it at all.
Yeah, Steve, did you want to come in?
Yeah, this doesn't just address this current question, but it just talks about thinking about the remote access through Skype generally, because I've seen some of those discussions also about assessing people, which is even much more complex, I suggest, than advocacy. But it's not just about whether it's acceptable, but you would need to ensure that you have agreement for somebody at the other end to support that person, wouldn't you? That's the important thing. I'm just thinking in the context of a police station mental health act assessment, you would need someone to be able to support that person. So it's not just having the technology, but you wouldn't also need some sort of a support staff there to support the person to be able to access that. With advocacy, it might be easier because the person may be less distressed. They wouldn't necessarily be in such a crisis. But if that does go forward, it's not just about the availability of technology. It's also about who's there at the other end to support the person with it. So there is still a human element that is of complexity there.
I mean, there's clearly this whole crisis is going to really throw up all sorts of new thinking about the place of digital, and we're going to both find things that work well in unexpected ways and also find all sorts of difficulties because digital equipment's not adequate or it doesn't fit for a particular type of social work intervention or support, but for other things it will. I suppose the other thing is that people who are using services are, like everybody, getting much more digitally. They've had lives that have grown up with more digital, especially younger people, so that it won't be so alien as it even was to people maybe just a few years ago. So those are all things to perhaps consider, but it's all challenging. Claire, did you want to come in on that?
I think there were two things that was occurring to me. One was how important it would be to evidence why that was the only safe way, the only practicable way to interview somebody. The other thing that occurred to me was that there may be a difference, for me as a practitioner, there may be a difference between an initial assessment and some other assessments or some other interventions, but that there will need to be an element of flexibility, because as Steve says, if somebody's on a ward, you can probably control a bit more the support that they can have with them while you do the assessment. But if they're in the community or if they're in the police station, it might be much more difficult to control that and to make sure that that's adequate.
Yes, I was thinking that one of the key things will be how the whole MDT, the whole multidisciplinary team, or the whole, all the different agencies are using different approaches, and the shared understanding of what's suitable and what needs to be in place to protect who gets protected, and does everybody get protected equally. I've got a question here, it's on different topic. Thank you to whoever's sent this in. It's about, are there any plans to fast track AMP trainees into full AMP roles? Mark, am I looking at you maybe for that? Or
Yes. So we are looking at every aspect of how we can enlarge the workforce, right? And I think the general theme is that we don't want to do anything that's unsafe to anybody, but we don't want to leave any option unlooked at. So in terms of AMP trainees, and I think Steve might have a view on this as well, we've certainly put this forward to Social Work England and DHSC as a possible option, and what's the views of it, and I know that Social Work England has gone off to think about it. And I think for me, when you look at the legislation, when you look at the regulations, it very much puts the power of deciding who is the right person to be an AMP into the hands of the local authority. And the local authority has to make a decision about whether they are a fit or proper person to do it. And normally when you're in the local authority, when you're managing AMP services, as I used to do, you would say, you know, are they an AMP? Have they done their 18 hours training, etc., etc. And I think in this case, we do have permission through the bill to be as flexible as we can be with it. So I think it's about local authorities deciding, is this safe? Now, for me, I would think that you would have to be at the end of your course. I know that a lot of AMP courses finish at different times of the year, but an awful lot of them are finishing around now, March, April. And I know that from my own experience, the AMP courses that I used to work with finished in March or April, and yet we weren't actually able to use the AMPs until later in the autumn because of the whole process. So if we have students that we feel are incredibly competent, have done all of their work, and that the local authority feels that proper people for them to be able to help out, that doesn't necessarily mean that they're out on their own doing assessments in someone's house, but certainly adding to the group of people who can work and support each other, then I think that local authorities would be able to put something in place to make that a safe process. Let's see what Steve and Claire have to say.
Steve?
I've gone into my normal geek mode, I think, and I'm just looking at the regulations here. And it does say in the past 5 years, in shortening it, a person must have completed a course approved by, where it says GSCC, but we know it's not that, but completed the course. So how do you define completed? I mean, it'd be interesting to see that. I mean, it doesn't say you must have passed it. I mean, by implication, that's obvious that yeah, anyone that's failed it won't be able to go through. But if somebody's completed it and to all intents and purposes passed it, just waiting for the exam board, notwithstanding the fact how Mark started off by saying that we must be cautious about brand new AMPs who have just done their training, throwing them into something as difficult as this. Every authority has to be very cautious about that. But I think that I would hope that we could be flexible by using that term completed. Because certainly when I was AMP lead, we had people waiting about 5 months from completion of course to the exam board. And, you know, we had to keep getting them shadowing to keep their skills up.
Do you think that raises then issues for, given that this is a seminar for PSWs and AMP leads, raises issues about how AMP leads, PSWs, workforce leads, managers, supervisors kind of can provide that, you know, the additional support that might be needed if somebody's being fast-tracked? I mean, they may be really able, they may be really experienced, and it might be quite appropriate, and that sort of 5-month lead-in is felt, it's kind of got longer and longer, hasn't it? And I can see why making that a bit more, you know, it's an opportunity here to really think about that. But it does mean that you need to step up the support in order to benefit from them being able to practice safely and confidently. So that might be an issue. Yeah, Claire.
I would agree. I think there is something important about AMP leads and particularly principal social workers, if they aren't themselves AMPs, finding out in their local areas what the situation is and thinking about, well, you know, how long is it between people coming back from a course and them being able to practice as AMPs? What's getting in the way? Do we need to make sure that people are released, for example, so that they can spend regular time on the on duty? Depending on the sort of course you're on, you may have been in the team where you work, or you may have been somewhere completely different. And I think depending on those scenarios, making sure people get the right experience when they get back and are supported is really important.
Okay, thank you. I've got a question that's come in on another topic, very important. It's about what discussions are taking place, if any, with service user organisations, and you know, individual service users and service user activists about their rights in the proposed changes. So, I mean, one of the issues I think for us as social workers, and I know it's something that we will be looking at as BASWA, ethical and rights issues of the new piece of legislation, not just in relation to mental health, but more generally, and what's proportionate and what is maybe disproportionate, or and of course the legislation is currently slated to potentially come in for 2 years, which is quite a long time for an emergency or urgent piece of legislation. But going back to the key point here, what about users' views about this, and obviously users' experience of effectively a condensed emergency emergency powers? Claire, do you want to Claire first, and then come to you, Mark? Is that okay?
Mm-hmm.
I've certainly been contacted as the chair of the PPEG by people who are concerned, understandably, about their rights being curtailed. And I do think it's really important for people to be reassured, first of all, that AMPs, whatever they do, will still have the obligation to work, to be actually assessing and making sure there aren't alternatives, and be able to say why, if they felt that they can't get 2 doctors, why that's the case, why they haven't done things in the way they normally would. And I think that's important. I also think that people need to understand how this law may come in, because as you said, it would come into force if the situation deteriorated to a point where it wasn't possible to follow the normal course. And one of the things I was wondering, Mark, is whether, if it comes in, does it come in for the whole country on a particular date, or is it regional? Because as we know at the moment, there is a particular pressure in London, and there may be other areas where there is less pressure. And I think it would be really useful to understand, well, what is the process? Is it for everybody? And how should people work with it if or when it comes in?
Mark,
Yes, sorry. That's a very good question, which I'm going to be honest and say I don't know the answer to. So we'll put it on our list of finding out what the answer is. I think in terms of the other questions that you asked, is there any discussion with people? I'm not involved in it, but I know that the Department of Health and Social Care has regular meetings with a whole range of people in, sort of like, for example, pressure groups, Rethink, Mind, all kinds of others, and also with a lot of service users groups as well. And so I would imagine that these things are coming up in those discussion groups, but I'm not actually involved in that myself. I think one of the issues for me is around what Claire said, that it's with, I suppose it's about, for us as AMPs, we don't, if this power comes in, we don't have to use the whole power. So like if something's extended from 24 hours to 36, then that's fairly reasonable. But if something's extended for a long time, I suppose it's the desire of this is to give us the opportunity that if we say we literally cannot do this today because we don't have the staff, then we then try and do it at the next available opportunity. And I think that possibly would give people some comfort. The other thing that I would say as well is that the Act, as it has not yet gone through Parliament. The expectation is that it will go through quite quickly and won't have a huge amount of objections to it. But one of the areas where I think perhaps it might have some pressure from the opposition is in terms of these timescales, because I know that in other emergency legislation, it's been reviewed every 6 months. So I wonder whether the Parliament might actually, the one thing it might do to this Act is to put in something that says, let's not just have it for 2 years, whether we want it or not. Let's have it reviewed every 6 months.
Yeah, and I mean, BASWA will be doing kind of commentary on kind of the key rights and ethics issues that we're picking up with the legislation, and that will be the time frame of it and the need for review, and whether it's even within the very real urgent situation we're in, whether 2 years without that is proportionate, will be one of the things that we're picking up over coming days. And we are anticipating that this legislation will go through, whether there's any amendments or not, it will go through very quickly. And so we need to be on top of that. So if anybody does have any issues around the bill, then please, I'll give a little push for the BASWA online. Share your experiences and views about what the hell's going on around coronavirus, which is available via our website, and you can access through social media feeds as well. We've had over 800 people send in their social workers sending observations of what's going on for them, their concerns, good practice as well, and we'll be getting information, findings out from that. But also you could add in any views you've got about this topic, and particularly about the emergency legislation. If you want to say anything, say it quickly, because this is going to move through very fast. We're running out of time. I'm going to ask one question, which I think might have a fairly quick answer, just as a final participant question before we wind up. And that question is, can we warrant registered social workers as a local authority if they haven't done the AMP training?
No.
No.
I thought that might be quite quick. Oh, Mark's got a caveat.
Well, I just wanted to say the answer to that is no. However, one of the things we haven't talked about, which I was expecting to come up, is can we warrant old ex-AMPs and ASWs, like me and Stephen here, to be able to come back in? You know, and I think that, so the answer to the first question is no, but I think there's a lot more flexibility if the local authority is satisfied that the person in front of them can act competently, especially with a little bit of quick retraining, that we might be able to use people whose career has gone off in a slightly different direction, but who essentially know what they're talking about.
The law still requires them to have done an AMP training or an AMP conversion, doesn't it? Is that right, Claire?
Not quite. What it requires is that they've either got to have done a AMP course and have been warranted within 5 years of that course, or that they've already acted as an AMP. They've been approved as an AMP since the law changed in 2007, 2008.
Yeah.
So as long as during that period, which is 13 years now, 12, 13 years, somebody has been an AMP, even if their approval has lapsed, they could be reapproved. The issue would be how the local authority satisfies itself that they've kept up to date. Now, they might have done so because they might have done what Steve's done, which is to go into training and other things, but not actually practice as an AMP. Or it may be that they've done something completely different and now want to come back. And if that's the case, it's about, well, can we give them some legal tests? Can we help them in some other way so that they feel confident? And so that service users and families feel confident that the people who are assessing them know what they're doing and are going to protect their rights.
Okay, thank you. Going to have to end it there, folks. We've got to the end of our time. Thank you to the large number of people who joined us online. I hope that was helpful. We do have another session on Monday and for AMPs, and in the meantime you will get the resources linked to this webinar. Thank you very much. There's going to be other webinars that BASWA will be running on a whole range of topics, and there will be one on deprivation of liberty and mental capacity matters next Wednesday at 2 o'clock also, and please look out for more, because we obviously need to explore all these issues. If you have any resources to share, please send them to the person whose email you have on the screen there, Wayne Reed, our professional officer in England, and then we will collate those and they can come out as part of the resources. Again, thank you very much indeed, and good luck and keep in touch.